Good morning all. Optic atrophy, a dive into the past. A 75 years old diabetic and hypertensive male presented with complaint of painless blurring of vision on looking downwards in right eye since 2 months. He gave history of cataract surgery of right eye done elsewhere in September 2024. On examination, his best corrected visual acuity was 6/12 parts and 6 in right eye and 6/6 parts and 6 in left eye. There was grade 1 RAPD and color desaturation in right eye. On fundus examination, there was optic disc pallor in the right eye. He presented with similar complaint to another hospital and they investigated him with HFA, OCT macula and MRI. On HFA, there was scotomas in the superior field and inferior nasal quadrant in the right eye. On OCT macula, there was parafoveal thinning in the right eye. MRI grain was normal. Combining all these investigational findings, they could not reach into a probable diagnosis, so patient came to our hospital for a second opinion. We investigated him with OCT RNFL and OCT GCC. There was superior, inferior and temporal thinning in the right eye in OCT RNFL and there was inferior and superior temporal thinning in the ganglion cell analysis. The findings on the GCC analysis and OCT RNFL was corresponding to the visual field changes. The inferior thinning in the GCC was explaining the superior scotomas and the superior temporal thinning was explaining the inferior nasal scotomas. And the superior and inferior thinning in the RNFL can be explained by the arrangement of nerve fiber layers in the retina. The temporal fibers are arching over the papillomacular bundle and ending in the superior and inferior bone. Comparing these findings, we reached in a most probable diagnosis of optic atrophy. So, slipping this case was GCC analysis. So, GCC analysis should be considered while evaluating a case of optic disc pallor. In this case, considering risk factors like diabetes, hypertension and cataract extraction, clinical feature of painless blurring of vision and no feature suggestive of inflammation, and an optic disc pallor and normal MRI and a segmental thinning on GCC analysis, and also the fact that most common cause of non-glaucomatous optic atrophy over the age of 50 years is NAION, we reached in a most probable diagnosis of optic atrophy due to NAION. Thank you.
To make a diagnosis of something that happened in the past. The learning curve over here was that the proper area of investigation should be tailored for every patient. The investigations done in the past did include the relevant features of MRI and the clinical examination, etc. But where the slip-up was in the OCT area that was examined. So in disease areas of interest and optic nerve diseases in OCT are usually the optic disc with the peripapillary RNFL, and in the macula, the areas of interest are the retinal nerve fiber layer, the ganglion cell layer and the inner plexiform layer, which are together called the ganglion cell complex. The importance of the PRNFL, that is the peripapillary RNFL and the GCC, is that damage to the anterior visual pathway may occur before the visual field changes, and these two layers in the OCT, they show changes in the OCT before the visual field changes, so allow for earlier diagnosis. These two changes in optic neuropathies, these two layers show thinning. And thinning of the GCC in the macula has been found to correlate with the visual loss and corresponding loss of visual field sensitivity in optic nerve diseases, as can be seen in this example, where there is a homonymous field defect and a homonymous thinning of the GCC. But sometimes, even when the field changes have resolved, you see the persistence of GCC changes. Pitfalls can trap you in OCT diagnosis, so you should be very careful when you are reading the OCT. And a reduction in signal strength causes artifacts in the layer segmentation of the RNFL and so in interpretation. Research all found that for each unit decrease in signal strength, as is seen in this case of cataract, the average RNFL thinning is seen to be about 2 micrometers, which with the decrease in the signal strength. Similarly, disc edema can also cause segmentation defects, and this is seen in the Disnet map. And an RNFL thickness sometimes approaches 0 in this Disnet map, and this is definitely a segmentation error, because even in very advanced cases of optic neuropathies, the remaining tissues will have some thickness, so it can never be 0. So also in the GCC. Errors in GCC segmentation often appear like segments of blue in the OCT, which is called a propeller sign. So such errors should be avoided when you're reading the OCT. The take-home message is that OCT is a very good tool in addition to clinical examination and other investigations. Look at the PRNFL and the GCC, not the macular thickness, etc. Make sure the OCT is captured well and with good strength. Thank you.
Field defect you are getting. It is not the typical field defect pattern you are getting as an area.
Yeah, that was one factor which may have the previous investigators may have made a slip, because it is not. Usually, what we see is a inferior field defect predominant. Here, what we saw was a superior defect with a spillover into the inferior field. So that may be the reason why they could not arrive at a diagnosis
Is there
or a
any
probable
field defect in the other
diagnosis.
eye also?
Pardon?
Any
No.
field defect? No,
No, there was no crowding of the disc which could give a clue to the diagnosis in this side. No other history that we could elicit. But however, he was hypertensive, so that is probably a predisposing factor.
Actually, there's no slip in, there's no snag in this case. No?
The snag or a slip is that the correct OCT was not seen. The reason they could not put the normal MRI, an optic atrophy, which is segmental in nature, that is, it was occupying 3 segments of the disc, and if they had done a PRNFL and a GCC, the picture may have fallen into place. But what they did was they did a macular analysis, like what you would do for a retinal disease. The layers that the retinal surgeon is looking at is quite different from the layers that a neuro-ophthalmologist is looking at in the macular scan. All the machines have this GCC analysis option. But if you just look at the macular scan and don't look at the GCC analysis, you may not get a clue from the OCT. So the learning point is that you have these investigations, but you have to look at the correct areas that the investigations project to be able to come at a proper diagnosis.
Anjali Prabhakar, Fellow, Squint and Pediatric Ophthalmology, Contrast Eye Hospital, Kozhikode, and her mentor is